Thank you. I'm happy to be here today. Let me make sure I have all of the stuff ready. Great. I'm Tom Kern. I'm a psychologist. I'm the director of pain psychology at Oregon Health and Science University in Portland, Oregon. I work in an academic institution, but I'm primarily a clinician. I like working with patients. That's my skill. That's where my passion is. And so I'm happy to be here as part of the consumer sessions. This is what I really like to do. So thank you for inviting me. Disclosures, no real disclosures. I don't know. I like to watch Bluey even if my grandson isn't there. Maybe that's my only disclosure. The outline. Today I want to talk about what is pain, what is PTSD, what do we do about them? So I want to define pain and PTSD, but then I want to present some of the research. What is the physiology of these things? What's the psychology of these things? And then I want to give you some actual recommendations, some take-home things, skills, strategies, techniques, things that you can do that don't rely upon someone else doing it to you or for you. So what is pain? We all know what pain is. We feel pain, but the International Association for the Study of Pain, this is like one of those pinnacle organizations. All the pain researchers meet together. It used to be every 4 years, like the Olympics, but then they made it every 2 years. But so way back in 1990, they decided we need an official definition of pain. And so they convened a committee. And then over those 4 years, they discussed back and forth and came up with this top one, their official definition of pain. And then they revised it in 2020. So, and they're very similar. So I want to look at this 2021. Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So the parts that I really want to emphasize, it's always unpleasant sensory experience and an emotional experience. We can't take the emotion out of pain. Pain is always an emotional event. So how do we deal with pain? We have pretty much one pain response. It's self-protective, it's guarding, it's activation of the sympathetic nervous system. It's the fight or flight response, but then they changed it to the fight, freeze, or flight response. And now the cool people are saying it's the fight, flight, freeze, or fawn. I can't even say it. But these are basically, it's the same thing. It's just added, I think, more correct dimensions of what happens when we go into that automatic. To me, it's the yikes response. It's what our body does anytime there's any threat to our well-being. It's an automatic response. It works well for acute pain. It does not work well for chronic pain. I'm going to say this over and over in this talk today. So long-term, persistent, or chronic pain, when pain persists, that automatic pain response has unintended negative consequences. It doesn't work well. So you think about that pain response, yikes. Our muscles tighten up. The longer we are in pain, the more muscle tension we get. The muscles start to get more stiff and sore. There's nervous system activation. Our nervous system is on guard saying something is wrong, I got to deal with it. But that makes our nerves more sensitive to everything, including pain. The longer it goes on, the more sensitized we become. There's changes in the heart rate and circulatory changes, there's digestive changes, there's emotional changes. So these things over time, it doesn't work well for us. It's good for short term. PTSD. What is PTSD? It's post-traumatic stress disorder. So PTSD is an anxiety disorder. If you categorize it in the categories within mental health, it falls in the anxiety disorders. And there are some specific components to it. There is avoidance of there has to be an initial event. So that initial event, it is either personally happening to you, or you could be witnessing that happen to someone else. It could be real life happening in front of you. It could be remote, like people after 9/11 had PTSD from watching planes go into the towers and watching it on TV, and they developed true PTSD from it. So it doesn't have to directly happen to you. I'm a parent. I know the feeling I get when I see one of my kids go through pain, and it is distressing to me. So you don't have to be the one personally experiencing whatever the trauma is. It's traumatic for everyone around. So there has to be that event. But then that event comes back over and over. There's intrusive thoughts that may be just thoughts in there all the time. Maybe it's flashbacks, maybe it's nightmares. There's avoidance of activities related to that initial trauma. So maybe going to any kind of a medical appointment starts becoming really unpleasant for medical PTSD. There's changes in physical and changes in emotional. Often people can get very irritable or strong-headed when they don't want to do something that has been associated with trauma in the past. My silly little example of PTSD, our bodies remember these things. I have an older brother. To this day, when my older brother walks behind me, I do this from all the years of getting smacked in the back of the head from my older brother. I haven't been smacked in the head by him for more than 30 years, I'm sure. He's sincerely apologized to me about how he treated me when we were growing up. I know he's not going to smack me in the back of the head. My body doesn't know that, and it still does this when he walks behind me. That's, it's not the disorder part, but that's my example of how it doesn't have to ruin life, but these are real things. So PTSD, there's medical PTSD. That's a real thing, and often the symptoms don't come up except around that one particular area of medical issues. So it doesn't have to be the person who moves away from life to live in a cabin in the woods to get away from it. But anytime it starts coming around these medical issues, that's when the symptoms come up. Complex PTSD or CPTSD. This is a new term, and it's not fully accepted by the mental health community yet, but it is basically, it's PTSD after repeated episodes of trauma. I don't know that there's really a difference, but I don't know, people always want to have one more thing and associate their name with it. I don't know. But so you may hear CPTSD, that's complex, repeated episodes of the same thing that kind of magnifies the whole effect. So to gain control over this stuff, we need to identify the triggers for those PTS symptoms. When you can identify them, you can prepare for them. So how do we deal with PTSD? It's the exact same as with pain. The body doesn't differentiate what the stressor is. Any threat to our well-being, it activates that sympathetic nervous system response. We have that one response to deal with any threat, the fight or flight. I want to mention that there are other treatments for PTSD that are sort of the gold standard. EMDR, eye movement desensitization reprogramming. That's the gold standard treatment for PTSD. It requires specific therapist training. It's not self-management, it's you have to go to the therapist. It is very intense. It takes commitment. It's also very effective. If you are truly struggling with PTSD and it's interfering with your life, I want to urge you to actually seek EMDR treatment. I don't get credit for, I don't get a commission on selling EMDR, but they're the gold standard. I want to urge you to seek treatment and actually deal with the problem. I'm going to go over some self-management things that you can take home and do yourself today. So I've talked about that sympathetic nervous system response. The body has that one yikes response. Doesn't matter what the stress is. So we've got that sympathetic nervous system activation. The opposite of that is the parasympathetic nervous system. That's the relaxation response, or the rest and digest, the kind of response. That's what I'm going to try to get your bodies to do when they're in that habit of holding that yikes response. We need to get it to move to that parasympathetic response. So the self-protective response, it works well for short-term acute problems. does not work well for chronic problems. I mentioned that. So why does this come up in patients with hemophilia? 89%, so this was a pretty recent study. They found that 89% of adult patients with hemophilia experienced chronic pain which interfered with their activities of daily living. That's a lot, 89%. And it's not just occasional. This is pain that truly interfered with their life. 39% of patients surveyed in the US believed that their pain was not well treated, and many reported using alcohol or other drugs to manage their pain. So pain is a huge problem, and for many of those patients, it's not well treated. There was a recent review article, Pain Management and Hemophilia Expert Recommendations. So I wanted to read that. Full disclosure, maybe I should have disclosed this. I'm not an expert in bleeding disorders. I'm an expert in pain management and PTSD. So I wanted to read some of the experts in hemophilia. And I found it very gratifying. The first thing that they recommended was psychology. And this was a long article. It took me a long time to go through it. And they said the goals of psychological intervention include patient dealing with the chronic illness, defining realistic goals, reducing patterns of fear and avoidance, that's kind of the PTSD stuff, creating strategies for coping with pain and stress, as well as developing adequate pain communication and problem-solving approaches. This helps improve compliance and quality of life. Today, I want you to leave here with strategies for coping with pain and communication skills and problem-solving tools. So they said a self-management program is something that's important. I want to go through an example of a typical self-management program, psychology self-management program for pain. So some of these goals: improve assessment of joint pain and other pain related to hemophilia, increase understanding of the difference between acute and chronic pain. This part is really important, recognizing the difference. Improving adherence to clotting factor treatment for acute pain. Improve knowledge and understanding about the benefits and costs of using pain medications, and that's particularly opioids. Increase positive motivation to self-manage pain. Reduce beliefs and attitudes that are obstacles to pain management. Reduce negative emotional thinking about pain. Increase acceptance of chronic joint pain. So that last part, acceptance, the goal is not to embrace it and, okay, I get my pain. I don't want you to ever like the pain that you have, but the acceptance part, and we're going to talk a little bit more about that, that's the understanding of the reality of your life. So that's the acceptance piece. So acute versus chronic pain, this is a crucial part. If we intervene early with an acute bleed, an acute pain episode, we can deal with it and prevent long-term chronic problems. So acute pain, what is acute pain? This is short-term pain. It's caused by injury, surgery, illness, trauma, medical procedures. It's a warning to the body that something is wrong. Generally, it lasts for a short period of time until the event is over or the body is healed. Often, people think of acute pain as being really intense pain, really severe pain. It's just a descriptor of the length of time. That's it. Chronic pain, this is long-term pain. Chronic pain can also be incredibly intense, incredibly painful. But this is pain that persists beyond healing. It is no longer that warning. It becomes a problem in and of itself. The pain is the problem. It's no longer just a sign that there's some other problem happening. So acute versus chronic, it's just a matter of the time. And one, we can deal with, let it go away. Chronic, unfortunately, we don't have a cure for chronic pain. And that's part of the definition. It's pain that's long-term. We do have things that work, and that's what we're going to get into today. So identifying and treating acute pain. If we can identify, okay, this is an acute problem, we need to deal with it. If we can deal with it quickly, often it doesn't lead to the problems that bring on chronic pain. So how does a patient identify acute pain? Is this an acute bleed? Does it feel different? Does it occur under different contexts or circumstances? So it's really important to learn the factors associated with acute pain. And this can be different individual to individual. I don't know that there's one formula that works for everyone, but the more you can recognize this is acute pain, these are my treatments, the more we can take control over it. Acute pain has that meaning there's damage occurring to the body. Please deal with it. If we don't deal with the acute pain, further damage occurs. That's when it leads to chronic, long-term, primarily joint pain. Acute bleeding episodes can be promptly treated with clotting factor and help prevent those long-term problems. Now, this is particularly important in children for a couple of reasons. One, the earlier we can intervene and prevent long-term problems, the better it is. But also, we have to teach the individual patient how to recognize that difference within them. Is this an acute issue, or is this just one of those kind of background pains that's part of life? One of the principles that comes up in everything that I read for this is the RICE principle, rest, ice, compression, elevation. It's one of those important elements in treating acute pain that's not all just medication related. So patients with hemophilia, the research suggests they do not adequately differentiate acute and chronic pain. So they use similar descriptors. They describe the pain in the same way. Many reported using clotting factor for chronic pain, and they didn't use it for acute pain. So it's, this seems to be a really important issue of addressing the acute pain early. So back to some of the recommendations from the experts. During acute phases, the RICE principle is used. Mobilization should follow as soon as possible. However, in order to be able to initiate physical measures, adequate pharmacological analgesia is paramount, and sufficient factor protection is equally important. I read that and said, what? And then I read it again and looked at it and said, okay, there are some medication things that we need to do right away, but then we need to do the self-management, the RICE things, rest, ice, compression, elevation. And then as soon as things are stable, we have to get up again. We have to get back into life. So it's not just, oh, do nothing and wait it out. We've got to act early. We have to be pretty assertive, maybe aggressive in treating that acute issue. And then we've got to get back up into life. So chronic pain. Chronic pain is, so it's defined in different ways based upon the sources you look at, but it's duration of time, usually pain that lasts beyond 3 months. But the one that I like is pain that lasts beyond the expected healing. So once the tissues are healed, once the body is healed, but pain continues, that's chronic pain. The European Hemophilia Therapy Standardization Board, I really like how they define this. They mention that chronic pain is continuous or intermittent pain, which occurs more than once a week for a period of 3 months or more. So it doesn't have to be chronic all day, everyday pain. It's repeated episodes of the same pain that also leads to chronic pain. It needs treatment. The treatments are different for the treatments for acute pain, but it also, we've got to have some understanding that chronic pain is a reality in life. It's going to be here. We don't have a way to immediately remove it. Acute versus chronic pain. So this is really busy. You'll have it in your handouts and the app. But I want to emphasize a few things, the things that are in red. The treatment course. So this is acute pain. This is chronic pain. The treatment for it. Immobilization is crucial for recovery from acute pain. Let's look at chronic pain. Immobilization makes it worse. Treatments, rest, activity avoidance. For chronic pain, we want to increase activity. For physical therapy, this is passive. It's the therapist doing it to you. For chronic pain, it's working together. It's you doing things on your own. Medication, often it's short acting. Often it can include opioids for acute pain. For chronic pain, we got to use caution with using opioids. For acute pain, the role of the professional, they're in charge. The doctor takes charge. They select and conduct the therapy. The role of the professional in chronic pain, it's a partnership. You're working together. They're more a teacher rather than the one telling you what to do or doing it to you. So the role of the patient in acute pain, you got to follow orders and let the body heal. In chronic pain, again, it's a partnership. It's working together. So the treatments for acute pain, if you look at them, they're very different from the treatments from chronic pain. And if we use the treatments for acute pain for a chronic condition, they don't work, and they can often make the situation even worse. Opioids, big issue in society, huge problem, yet I want to emphasize opioids are not always evil. We need to be careful. We need to be wise. They work. There's a reason that they work. There's a reason that they're used so often. They do work. They're better for acute pain than for chronic pain. Opioids will sometimes make the situation worse rather than better, especially with chronic pain, but they're not always evil. Chronic pain management. So the goals for managing chronic pain, reducing the pain, that's the primary goal. And notice I don't say pain elimination. That's probably not a realistic goal. It's reducing the pain, gaining control over the pain, improving physical functioning, improving quality of life, and decreasing the suffering that goes along with it. The suffering is the emotional response. The core elements, there are some medications that are very good for long-term pain, chronic pain. There are some physical exercise, physical tasks. There are some mental exercises and strategies and some emotional strategies. And we've got to incorporate all of these because they're all affected by chronic pain. So I mentioned acceptance a while ago. Acceptance, to me, there's two stages of it. Acceptance, that's acknowledgement. Yes, I have this. That's that basic understanding. But that's not the destination. To me, that's only a beginning step in the process. The longer part is adaptation. If I've accepted, okay, this is my reality, the longer term part is, now what? It's doing things in different ways. There are many different pathways to arrive at that same destination, but if we have a condition that interferes with normal life, we need to find different ways to live normal life within the realities of that condition. So to me, that's what acceptance is, and it's way more adaptation than it is acceptance. Lifestyle changes. We've got to do things in different ways. We've got to take care of our own body. We've got to eat well. We have to hydrate. We have to move. We have to sleep well. We have to avoid. So when I put these in here, I was wondering if these two last things are kind of contradictory. Minimize mood-altering substances, but then have fun. I truly believe we can do both. When I meet with my patients, I almost always, I will ask them some of these basic questions. How are you doing with basic self-care? How are you doing with nutrition, hydration, allowing yourself enough time for sleep? And where I work, they have patients fill out, patient satisfaction surveys. And one comment that repeatedly comes up over and over in my surveys is, he holds me accountable for self-care, and it really helps. Just that little bit of making sure we're doing the daily things to take care of our own body. When we've got big problems that we deal with all day, every day, it's easy to neglect some of the basics of eating good food and drinking and actually leaving the house. That was one huge thing, especially in pandemic. I would ask people, have you left the house this week? And it's amazing how many people didn't, often still don't. And sleep, pain can interfere with sleep, but so can lifestyle. And so I kind of choose my words carefully on that one. I say, are you allowing yourself enough time to get good sleep? Because often they interfere with sleep because they're on their phone until 3 o'clock in the morning. They're just not allowing themselves enough time to truly get good sleep. So Physical activity. There are things in physical therapy that absolutely can help. I don't want to take the place of a physical therapist. I don't know their job. I look at the things that the individual can do and that I can assist them with. And the one thing that I really liked in the recommendations that I saw regarding the physical was 30 minutes of exercise at least 3 times per week. So, and it has a significant effect on increasing range of motion, and it reduces joint pain. Physical activity, 30 minutes of exercise. So this exercise piece, that has negative connotations. Exercise is unpleasant, it's sweaty, it hurts, it's hard to do. So I want to talk about activity, 30 minutes of movement. This can be gentle. This is going for a walk. This is, if you're going to the mall, go into the mall, walk down to the end, turn around and walk back, and then start your shopping. So it's a 30-minute walk at a comfortable pace. Hopefully you do it with somebody you like. 2 people are more successful than 1 in any of this. So anything that gets your body moving counts. It doesn't have to be sweaty, out of breath, hit the target heart rate, hire the trainer at the gym to be effective for these goals. More lifestyle changes. Prevention is better than intervention. I think it's better to prevent a problem than to try to clean up a mess after things have gone badly. I think 1 tool is better than none, but more tools are better than 1. If you've got 10 tools, that's great. So these tools, pain coping skills, stress reduction, pacing strategies, distraction, and we talked about acceptance and adaptation. I'm going to go in detail about these coping skills. These are the things that I hope you'll be able to leave here today with. So stress reduction. Now, I want to say some of these things are going to sound very simplistic. Don't dismiss them just because they sound simplistic. Some of the simplest things can be some of the most effective things. For example, diaphragmatic breathing. Perhaps the quickest, the most effective way to counteract that physiologic pain response, the sympathetic nervous system yikes response, is breathing. The right type, the right rhythms and techniques of breathing, they work on human bodies. It's a very predictable response, and it's the exact opposite from that sympathetic nervous system response. There's progressive relaxation. This is like muscle group to muscle group. You kind of go through your body. It's the head, shoulders, knees, and toes, or body inventory, however you want to call it. I've done this for a lot of years, and when I started in training, we all had the same guidebook to teach us progressive relaxation, and it was this plastic book that had cassette tapes in there to teach us sort of the banter to do along with it. And you'd start with the toes and flex the muscles and let them relax and work up the body. Come to find out, most of those techniques were counterproductive with chronic pain. When you tighten the muscles, you just sort of irritate. You can activate that whole sympathetic nervous system response. So that part of it tended to not be very effective. And you think about the part of the body that is the most reactive to any stressor. When we are in pain, we go, it's this part of the body that's the first to tighten and the last to relax. If we hold our shoulders up, we feel revved up. If we get them to relax, the rest of the body starts to calm. So come to find out, starting at the toes and working up is way less effective than starting at the top and working down. We get these muscles to relax, the rest of the body starts to follow along. So some of those old traditions still hang around in the things that I read and the things that I hear professionals talking about. And I will often ask them, why do you start at the toes rather than the head? And the answer is, well, that's the way I was taught. And often, the old habits just hang around. So start at the top rather than the bottom if you do that kind of relaxation. We're going to get into diaphragmatic breathing. I'm sure hopefully, you've had some exposure to breathing techniques. It's a very common strategy for dealing with any kind of stress. Take a deep breath. But there are different ways to do this. And so I want to talk about one particular rhythm and style of diaphragmatic breathing, of gentle breathing. Now, you can go out and find all kinds of other strategies. Give them a try, see what works best for you. But I want to go over one that I think is the quickest. I think it is the most simple. And honestly, I think it's the most effective. So the first step in this is relaxing abdominal muscles. This is diaphragmatic breathing. You relax that big wide diaphragm muscle that's under your lungs. Really, it's belly breathing. So that when you take in a breath and lungs fill up, it pushes everything out at the belly, because that's the softest area when you take in that breath. You think about watching a little child sleep, lying on their back. It's that round tummy that's going up and down. It's not the rib cage. You watch a dog sleeping, it's his belly that's moving when they breathe. It's not the rib cage. But then once we get into teenage years, we learn that it's good to look flat here. So socially, we start holding these muscles tight. And then part of the body's pain response, it's self-protective. The body tries to protect vital organs. So our abdominal muscles automatically tighten when we are in pain. If we relax abdominal muscles, that starts to get the body to relax. It sends a very clear message to the brain and the body that it's safe to let the guard down. We're making vital organs vulnerable. The only time we do that is when we're in a safe environment. So that's why you do the belly breathing, the diaphragmatic breathing. So step one is relax abdominal muscles. That can take a little bit of practice, but that's step one. The next step is to breathe in gently, just to the point that the belly expands, but not to the point that it gets into expanding the chest. It's a gentle inhalation. Think about what we automatically do if we get startled by something. We take in a breath and hold it. If we get a sharp pain, it's like breath on top of breath, and we hold it. We are taking a big breath in and we're holding on to it. That's the sympathetic nervous system. That's that yikes response. I don't want you to kick that in when you take in this breath. I want you to inhale gently, like maybe 2/3 of as deep as you can get for the inhalation. Then I want you to immediately open your mouth and let the breath fall right back out. You don't hold on to your breath, you let it back out. And you think about that. If we get startled, we take in a breath and we hold it. Think what we automatically do when the pressure's off. We go, whew. That's how I want you to exhale, is just let the breath fall out of you to the point where it stops on its own. You're not pushing out every last little bit. But it's also not blowing it out quickly, and it's not measuring it out slowly. When we go, we don't go, we just let it fall out. So we're capitalizing on what the body automatically does. Let the breath out to the point where it stops on its own, and then rest there for a few seconds. So that part of it, you're not doing anything. You don't breathe in, you don't breathe out, you just rest for a few seconds. That feels a little bit odd. We're used to taking a breath in as soon as we exhale. You're not going to run out of oxygen. You just had a good breath, but it takes a little bit of practice. When we exhale in this way, that type of exhalation stimulates the parasympathetic nervous system that I mentioned is the relaxation response. But actually the biggest change in the body comes after the breath stops, before we breathe in again. That's where that pause becomes so important. That's where your body changes the most. So then we have to repeat this. And this is not 20 minutes every morning of practice. It doesn't have to be that long. It's more like 1 minute of practice, but do this 20 times a day. The idea is small bits of time, lots of repetitions. Okay, there we go. I said 10 times a day. And our bodies develop physical habits. When we have chronic pain, our body develops that habit of expecting pain. And we stay in that guarded state at some level, even when there's pain, even when there's not pain there. We're thinking, yeah, but I know it's coming. Like if my brother would come into the house, I know it's coming. So I want you to get the body out of that habit of holding that pain response and into the habit of being more physiologically neutral, even if there's pain there. That takes practice. That's getting your body to do the exact opposite from what it automatically does, but it works. So I think we have time. I want to have you do this for like 1 minute. I want you to kind of let your shoulders relax. Lean against the back of the chair. Let your belly go soft and take in a gentle breath. Just a gentle inhalation. Then open your mouth and let the breath fall right back out. And then don't breathe in, don't breathe out. Just rest there for a few seconds. And then take in another gentle breath. In through the nose. Open your mouth, let it right back out. Let your back relax as the air goes out. And then rest there for a few seconds. Don't breathe in, don't breathe out. Take in another gentle breath. Let it right back out. Let your back relax. Rest there for a few seconds. This is one of the quickest, one of the most effective ways to counteract that sympathetic nervous system activation, the body's automatic pain response. It works quickly. It's a very predictable response in human bodies, and it brings on that parasympathetic relaxation response. This is something that you can do sitting, standing, lying down. It doesn't matter. It works. And it's also one of these things that's so simple, it's easy to dismiss. Long ago, when I was doing a fellowship, tail end of my training, I had a mentor. I'm still in contact with him. We had a treatment group that we were doing. It was at a VA in Portland. And he said, okay, today we're going to do relaxation with this group. And he said, I want you to teach them diaphragmatic breathing. And so I'm this, young punk just out of school. I thought I knew everything. And I said, well, what about some guided imagery? And what about some progressive relaxation? All these things that were pretty complicated. And he smiled and he said, you can teach them whatever you want. Just make sure you also teach them this diaphragmatic breathing. And so I begrudgingly taught this along with the rest of the stuff. And then the next week when the patients came back, I was asking them, what'd you think about the guided meditations and stuff? And they said, oh, well, we didn't do those. The one that worked was the diaphragmatic breathing. And hearing that a few sessions, I got the message. So it's such a simple technique, but it also works. Gentle stretching. The opposite of activation is relaxation. The opposite of tension is stretching. A muscle cannot be tense and stretched at the same time. So if we do some gentle stretching, just rolling our shoulders, that brings relaxation to the whole body. There's really interesting research on peripheral blood flow. These are old studies. Back when biofeedback was sort of all the rage, they measured finger temperature, toe temperature. When people roll their shoulders, their hands warm up, their feet warm up, because those little capillaries start to expand. Part of the stress response, the sympathetic response, is constriction of those little blood vessels. We just roll our shoulders in a circle and the whole body starts to relax. And I'm doing this, that feels good. I actually feel it in my fingers, in my legs. You can bend at the middle, make your back round, and stretch all along your spine. And yoga has great names for these things, great techniques for these things. There's tons of evidence that yoga is very effective at managing chronic pain. But what I want to emphasize is that you don't need to know yoga. You don't need to sign up for a yoga class to get benefit from this. You can roll your shoulders. You can just bend down and be, pulling up your socks, but still making your back round and stretching all of those muscles. And these are things, the diaphragmatic breathing, rolling the shoulders, these kind of stretches, you can do these anytime, any place. You don't look like a nut while you're doing it. If you roll your shoulders, someone may see you and they'll start doing it as well because it feels good. And they're very effective at getting the body away from that sympathetic nervous system response into the relaxation response, the parasympathetic. Pacing strategies. Pacing, this is not walking back and forth. This is recognizing the body's physical limits and respecting those limits. So there are real limits to what the body will tolerate. If you go beyond those limits, you're going to pay for it. We need to respect those limits. This is not no pain, no gain. So we need to plan. We need to make a plan within those realities of what the limits are. Plan a stopping point. Plan this stopping point before you begin the task. And when you get to that stopping point, take a break. This is brief, purposeful. It is to bring on that that relaxation response, set your next stopping point, and then get back to what you were doing. So when you take the break, this is not, I'm going to take a break from mowing the lawn and start weeding the flower bed. It's taking a break from mowing the lawn by sitting down and doing some breathing and some stretching before I go and do the next little portion of lawn that's within my physical limits. I'm not a big believer in willpower. I'll remember to stop. We don't. We get caught up in what we're doing and we forget and we push too far and we go until the point that the body starts really telling us we need to stop. And by that time, we've kind of gone beyond the limits. The example I like to use is after a car goes off the edge of the cliff, it does no good to put on the brakes. You're going to hit bottom. You got to put on the brakes before you get to the edge of the cliff. The closer you are, the more at risk you are. So if you know that you have an hour of tolerance for whatever the task is, don't go for an hour, because that hour will lead to an hour and 15 or an hour and 20 because I'm almost done. I just want to finish. Stop at 45 minutes while you still have a cushion there. Take a break, make that break purposeful, use some of these techniques that we've talked about, and then get back to what you're doing. And it's frustrating to do this. You think about our work ethic. Our culture teaches us to push the limits, no pain, no gain. And we teach our kids, finish your chores and then you can go play, kind of things. What I'm suggesting that you do is that you stop in the middle of a task before you're finished with it while you're still feeling okay, and take a break. And if you think about our work ethic, that's wrong in every way. We're taught to push the limits. So set a timer. And this takes practice. And I've had patients kind of challenge me on this. And so I asked them to do an experiment. Do it my way for a week, do it your way for a week, and see which works out better. See which way you end up accomplishing more, because it's really frustrating to stop in the middle of a task. And I'm quite confident in making that challenge, because I've never had anyone come back and say, well, that didn't work. This is one of those strategies that works. Distraction is another one of these things. So most people can recognize a time when they didn't notice pain as much. And I'll ask for their personal examples. And often these are things of, if I'm watching my kid do something, or if I'm watching a sporting event and it's really close, and they'll notice that, pain's off to the sidelines a little bit when they're doing that. Long ago, pain researchers, pain practitioners, they came up with this concept of a pain gate, which can be opened or closed. Now, this one is like the anesthesiologist's description of the pain gate. I don't understand any of that. I'm a psychologist. This is ours. The gate is open. This is the site of the pain. The pain message gets straight through to the brain. Or the pain gate is closed. The site of the pain, it gets blocked by that pain gate. So there's no actual gate in our spinal cord. But there's a lot of things that work to interfere with that pain message getting through to our brain. The nervous system is very powerful, and that includes the brain. It's powerful. We can close that pain gate, and a more updated descriptor of this pain gate is neuroplasticity, which is a term that's become popular in recent years. I remember a couple years ago being at Joann's or Michael's or whatever craft store, seeing this big display of these detailed coloring books, and it was neuroplasticity and mindfulness, I think, was the two things that they had on there for these detailed coloring books. And there's actual truth to that. So when pain is very difficult to control, distraction can be a really good tool. And I want to talk about how that works. So there's this certain type of MRI, functional MRI, fMRI. It shows us which part of the brain is being activated while people are doing things. It actually measures the oxygen usage in the brain. Where there's more nervous system activity, it uses more oxygen, and so it lights up bright. This top one is a patient with chronic low back pain. This bottom one is a patient without chronic pain. And in this study, the researchers pinched the thumb of the patient. So they weren't poking them in the back that was their sore spot. They were pinching their thumb, enough to go, ow, but not enough to damage anything, just ow. And just with pinching the thumb, Look at the difference in the brains. These are the pain parts of the brain, the pain receptor parts of the brain. People in chronic pain, the longer we are in pain, the more sensitized we become to that pain. We don't get used to pain over time. We actually become more and more sensitive to it. And they call this central sensitization. It truly happens. And the longer a person is in chronic pain, the worse it gets. And there's a very big difference, as you can see, difference between people who have pain and people who don't. So there are ways to reduce this central sensitization. If we activate parts of the brain that are not involved in that pain processing part of the brain, we can start to reduce the pain response, reduce our pain sensation, and over time, reduce that increasing sensitization. Some distractions are better than others. The ones that tend to work the best, they involve sort of the outer parts of the brain, the more human, higher cognitive functioning. If you think of the humanities department at a university, art, music, literature, architecture, design, sort of the beauty, the creative things in the world, those things tend to work really well. And we've known this for a long time. In 1697, William Congreve wrote, "Music hath charms to soothe the savage beast." He understood this. Now we have objective evidence that actually shows how this works. So here's another objective evidence of how this works. This is a patient who has chronic pain, and they're using virtual reality, like Oculus kind of things. So the top one is just them in pain. This one is when they put on the virtual reality glasses and start getting engaged in, basically it's a video game, but it's a very immersive video game that's visual and some tactile, you move around a little bit, and some auditory. Look at the changes, and that is distraction. So people say, well, how can, watching if you're a football fan, how can watching a football game help my pain? That's exactly how watching a football game can help your pain. And any of you gamers, if you're looking for an excuse to buy your Oculus thing, here's your excuse. So in real life, there are some exercises that are very easy to do that capitalize on this information. The first one, kind of a gimmicky sounding title to it that just makes it easy to remember. This is see, hear, feel, 5, 4, 3, 2, 1. So what this actually means is that you sit down or lie down. This is actually a very effective sleep management technique. So if you're lying in bed, the goal is to see 5 different things. And I wouldn't suggest that you look around the room, 1, 2, 3, 4, 5. I suggest that you look in one spot. Or you can even do this with your eyes closed, because we see all kinds of weird things, colors and shapes and stuff with our eyes closed. But the goal is to see 5 things. Then shift your attention to what can I hear. If it's a nighttime, if it's at night, it may be really quiet. Maybe it's your own breathing or your head moving on the pillow or something. But you hear 5 different sounds. Then shift your attention to what can I physically feel. These are non-pain sensations. Physically feel 5 things. So as I'm standing here right now, I start to feel my feet against the floor. I felt my sleeve on my wrist, things that I wasn't aware of a moment ago, but when I take my attention to them, I focus on that, and I stop focusing on my hip that's uncomfortable. Then, so you see, hear, feel 5 things. Then go back and see 4 of those things. I like to go back to the same place I was looking, but the goal is to just see 4 things and really see them. Then shift to hear just 4 of the sounds. Then feel just 4 of those sensations. Then go back and see 3 things and hear 3, feel 3, and then 2, and then 1. And what we are doing is systematically activating these different parts of our brain that are not involved with that pain processing, and we're gradually turning down the volume on all of that sensitization till you kind of get down to just one thing. The body's calm, the brain is calm. Often people are asleep before they get to that just one thing. So see, hear, feel, 5, 4, 3, 2, 1. Really effective technique. Another technique is to choose one of those senses and really focus in on it. So for example, there's interesting research of people listening to music. It's not just music in the background. This is headphones or earbuds or something, but it's not just, oh, I like that song. It's focusing on the details. It's hearing the melody rather than the more obvious harmony. It's choosing one instrument and following it through the piece of music. So you're really hearing the details. And the more we hear, or the more we listen, the more we hear. And it starts to activate the creative part of the brain and the auditory part, and it reduces activity in the pain part of the brain. You can do this visually. Look at something and see the details. If you look at a painting or a photograph, see the brush strokes, the light and the shadow, the subtle little details, rather than just, oh, that's a pretty picture. And it doesn't matter which of the senses. We have all of our, so many fine motor sensations in our fingertips. You pick up something that feels interesting. These things work. And you don't have to do it yourself to appreciate this. But if you are one of those creative people, this is where those detailed coloring books that became so popular, they truly work. When we do something creative, we activate those parts of the brain. And finally, getting involved in just life in general. Pain affects so much more than just the part of the body that hurts. It affects our work, our family, friends, relationships, fun, spirituality. Treating chronic pain isn't just treating that part of the body that hurts. It's the whole big picture. It affects so much more than just the part of the body that works. Hopefully these are some tools that allow patients with chronic pain to re-engage in their life. So your homework, identify those PTSD triggers, prepare for them. Identify pain triggers, avoid them if you can, prepare for them if you can't avoid them. Practice the diaphragmatic breathing and the gentle stretching that we went over. Practice that sensory meditation, the see, hear, feel, 5, 4, 3, 2, 1. And then increase your activity. Leave the house. Walk to the mailbox. And that's it for me. So we have time for questions now.